Okay, welcome to GM Insights. I am Emma Matovu. I'm an associate director here at Georgia Meminet for the Primary Care Provider Core. Dr. Ted Johnson, our lead for this program, is on vacation, so I will be introducing our speaker today and manning the Q&A chat for you. And so joining me today is Kim Reese, who is a senior program coordinator with the PCP Core. And our speaker today is Dr. Lee Jennings, who is an associate professor of medicine and chief Reynolds section of geriatrics and palliative medicine at the University of Oklahoma Health Sciences Center, and a geriatrician and health services researcher whose work focuses on improving models of care delivery for persons with dementia and their family caregivers. She has established a statewide older adult health education community outreach program focused on dementia healthcare workforce development and fall prevention in Oklahoma. For GMN, Dr. Jennings has presented at GM Insight sessions in the past and also at our annual PCP Symposium. She's also one of the faculty speakers on the GMN online course, Mind Matters, Dementia Care for PCPs. We are very excited to have her today. Welcome, Dr. Jennings. The floor is yours.
Thank you, Emma. You make me sound so good. Thank you for that introduction. So again, my name is Lee Jennings, and I'm really going to be talking to you today kind of with my primary care geriatrician hat on. So I have a primary care practice in the outpatient setting at OU Health. And when I was preparing this talk, I was really thinking about, what would I want to know, or what questions that I have as a primary care doctor about prevention of cognitive impairment? What can we do in that primary care setting? So hopefully this will be useful to you guys today. Okay, and here is the accreditation statement and the designation statement, and as well as disclosures. And I have no relevant disclosures related to the talk today. And here's what we're going to cover. So I'm going to talk a little bit about what's kind of the background about why we have sort of this renewed interest in risk factors for brain health. And then what are some of those modifiable risk factors and the evidence behind them? And then what are interventions also that have evidence that we can impact in primary care? And in no way are we going to cover every risk factor and every intervention. So we're going to hit the highlights and we're going to use a case as an example. So I wanted to start with this slide because, so this was actually a similar version of this slide was one that I saw recently at a meeting, and it really made me think about how I'm approaching cognitive impairment and dementia risk factors differently in my primary care clinic. And the thing that really struck me here is that, we know mixed pathology is common, but it's really the rule. So this was a study that looked at post-mortem, that looked at pathology, brain pathology. And what was striking about this is that only 4% of the time was it Alzheimer's disease pathology alone. It's really mixed pathology the rest of the time. And I also wanted to point out how common vascular pathology is. So vascular is the pink, the blue, the green, and the yellow. So really the majority of the pie. And we know that we have interventions to impact vascular disease. And so, what's good for the heart is good for the brain, right? I think we probably all said that to our patients, but this really, I think, demonstrated at a biological level kind of why paying attention to some of these risk factors is so important for patients that we see who have cognitive impairment or who we know are at risk. And then the other thing that I think is striking and important in thinking about cognitive prevention of cognitive impairment is that we know that the brain pathology begins way before symptoms, right? So 20 years out, we know that there are neuropathological changes occurring, but we're not going to see the clinical manifestations of those for decades. But that also gives us an opportunity, right? It gives us huge lead time for us to impact vascular risk and some other risk factors that we'll go through today. So, and that's what we do in primary care, right? Is we're thinking about prevention. So really thinking about those interventions for prevention is really important for brain health because we actually have time to intervene. And the other thing I think that's important about this is that even if we were to develop drugs that really impact Alzheimer's disease pathology, remember that that's just one pathology. So all of our patients still also have all of those other pathologies happening that we need to be thinking about how we can impact risk factors for. Okay. And then there's been increasing data, and this was a 2024 revision of a Lancet article that looked at modifiable risk factors for dementia. And we know that we can prevent or delay dementia through lifestyle and public health change. That's really been kind of, I think, a breakthrough in the last decade or so. And this was a figure looking at all of these risk factors. And if we were to impact all of these risk factors, we'd actually have a 45% reduction. 45% of dementia cases are potentially modifiable with these risk factors. And some are late life, but many are midlife, right? So that's, again, where we've got adults in primary care who maybe don't have cognitive impairment, but we ought to be thinking about what can we be doing to help prevent that as they age. And then lastly, this is a slide that sort of, I think, outlines the plausible biological mechanisms through which many of these interventions work, right? So everything in this blue, all these things in the blue boxes really fall into our domain in primary care, right? We manage diabetes, cholesterol, hypertension, smoking cessation, obesity, head injury, depression, alcohol use, hearing loss, vision impairment. All of these things are things that are, routinely part of primary care, and they have biological mechanisms through which they may be ultimately impacting cognitive health. And so again, gives us an opportunity to prevent and delay. But what's the data, right? So, okay, so that's all theory. So what's the data? So backing up some of these assertions. And so this was a Finnish study called the Finger study. And it was almost about 10 years ago now. So it was published in 2015. And it was a randomized controlled trial of 1,260 persons aged 60 to 77 who had cardiovascular risk factors and mild cognitive impairment. So they defined that as a mini mental status exam score less than or equal to 26, or this impaired word recall task, but they also excluded people who had dementia, which they defined as MMSE less than 20. So they basically took people with kind of the small range of MMSE scores between 20 and 26, so this MCI population who also had cardiovascular risk. And they got a 2-year pretty intensive intervention, including regular exercise, diet modification, cognitive training 3 times a week, vascular risk monitoring and feedback and changes in medications. And the control group was general health advice. And their primary outcome was change in cognition, and they used a comprehensive neuropsychiatric battery for that. What they found, and this is the total battery score here. And then on the upper right, we have the change in executive function, process speed, and memory. And a higher Z-score here shows cognitive improvement. So everybody got better, but the intervention arm had improvement in their total score, which was really driven by improvement in executive functioning and in processing speed. They really didn't see change in memory. And this was, again, these are 2-year outcomes. And then this is a little bit hard to understand, a change in Z-score. So I also included the odds ratios down here, and they had about a 30% improvement over control group in their cognitive scores at 2 years, based on this multimodal intervention that we know impacts vascular risk, and it showed improved cognition in these people. And this study has now gone on long enough that they've done several follow-up studies. So at 2 years, the intervention group also had maintained their ADL. So whereas in the control group, they had worsening of their activities of daily living, so increased disability in the control group. The intervention arm also had better self-reported health-related quality of life, which they measured with the SF-36. And then the intervention arm also had decreased risk of developing new chronic diseases, a hazard ratio of about 0.8. And then they've also done longer studies, so 7 years. They showed a lower incidence of TIA and stroke in the intervention versus control with a hazard ratio of 0.7. And then among those study participants who already had a cardiovascular event, the impact was even higher, right? So they had a hazard ratio of 0.5, so a decreased risk for recurrent cardiovascular event. So that's been very promising. And now there are actually finger studies or versions of that. The one in the United States is called the US Pointer Trial, so some sort of version of a digit in the name of the study here, all over the world. And I believe that the US Pointer study results, the top line results, are expected to be announced at the Alzheimer's Association International Conference coming up later this month. So we'll see kind of how these interventions have translated to other populations beyond Finland, but it is promising to see, that those interventions that we kind of tout in primary care can have lasting impacts. Okay, for brain health. Okay, so I wanted to kind of transition to a case. So that's kind of some of the background about why this is important and what the prior data has showed us. So let's see if we can apply it to a patient that hopefully kind of resonates with you all. Hopefully you've seen someone like this patient in your own practice. So this is a 67-year-old man with obesity. His BMI is 34. He has type 2 diabetes. Last A1C is 7.4. Hypertension, peripheral neuropathy, and stage 3B chronic kidney disease. And his primary complaint when he comes in is cognitive concerns. His wife has noticed that he repeats himself in conversation. He introduced himself to somebody he already met recently at a party, a social event they went to. He does all of his instrumental activities of daily living independently. He uses a pill planner for his medications, and he recently retired from work as an accountant. He also reports that he frequently feels tired during the day. You say, hey, do you snore? And his wife says, yeah, he sure does. And his medications include lisinopril, dapagliflozin, and SGL2, I have trouble with that word, atorvastatin, and gabapentin, 600 milligrams twice a day. So, he sort of looks at you and says, what should I do, doc? So, the question is, what are you going to recommend next? What are you going to do next for this guy? And so here is our kind of our multiple choice question. We're gonna have a little poll here. So in addition to counseling about diet and exercise, do you start tirzepatide? So this is a GLP-1 receptor agonist. Do you start that for weight loss, diabetes, and chronic kidney disease? Do you taper the gabapentin? It's a high-risk med. Do you order a sleep study? Remember, he snores, he's tired. Or do you do a Montreal cognitive assessment? Because cognitive concerns were sort of the reason he came in today, chief complaint. And so you'll tell me when we can see the results?
Yes, I'll let you know.
Perfect. And if you're feeling a little conflict, that's okay. The case might have been designed that way. So just go ahead and put your money down.
Looks like we have about half of the audience that have completed the poll. Oh, there's still a couple of more coming in, so I'll wait a couple of more seconds. Okay, I'll go ahead and end it.
Okay, so we've got most votes for doing a kind of another kind of assessment, figuring out where he's at, and ordering a sleep study. So I will tell you that there are data actually to back up all of these choices, and we're going to go through some of that. So we'll close. If we can go ahead and maybe I can close this now. Let's go ahead and go on to the next slide. Can I do that? Maybe. There we go. So I actually started with a sleep study in this patient. So what's the evidence for that? So we know that untreated sleep apnea is a risk factor for cognitive impairment, for dementia syndrome. And in studies, the hazard ratio is somewhere between 1.1 and 1.5. And so I looked at the data, and there was a pretty high quality meta-analysis of obstructive sleep apnea and dementia risk, included 11 studies of 1.3 million people. And they found a hazard ratio of 1.4 for untreated sleep apnea and then a resulting neurocognitive disorder. And these are all observational studies. And then what about CPAP? If you start CPAP, does that then mitigate, the cognitive decline? And studies are a little bit mixed here, right? So there, again, another meta-analysis of cognitive benefits of CPAP included over 60,000 people who had obstructive sleep apnea. And then in 9 of 11 studies, 3 of which were randomized clinical trials and 8 were observational studies, they showed a protective effect of positive airway pressure on the incidence of mild cognitive impairment and Alzheimer's disease incidence. So reasonable data to suggest, at least in my interpretation here, that treating sleep apnea is a reasonable intervention for people who have early cognitive symptoms, because we know that untreated, it does increase their risk over time. but my patient won't wear CPAP, right? So this is the most common thing I think we run into in clinical care. So what can you do to encourage people to wear CPAP? So this again was a Cochrane review of 41 studies of about 9,000 people. And what they found was that behavioral intervention, this included a couple of different interventions, motivational interviewing, cognitive behavioral therapy, adherence coaching. And if people got that, they wore their CPAP about an hour, 1.3 hours more per night on average. And then the number needed to treat to get people to wear CPAP at least 4 hours a night was 8. So that's not a bad number needed to treat. So I've been thinking more about trying to actually refer people for cognitive behavioral therapy if you have access to that, right? That can be just difficult, but if you have it for in sleep and insomnia, you have somebody who has worked with patients to have OSA, I've been trying to do that because if you can get them to accept those interventions, then it does increase their adherence and their CPAP use. What about automated feedback from the CPAP machine? This would be like they got some kind of a signal that then triggered the clinician to try to intervene. And that also worked. That also increased CPAP use by a little less than an hour a night. Number needed to treat was 9. And then device optimization. This was another component of it. So if you can use nasal instead of oronasal, that's preferred. Auto titrating CPAP for pressure adjustment works better. Heated humidification, so that's not as drying. And then I think this is really key in practice, early and flexible contact by the DME providers, right? So often the patient actually will know what they need, but they're having trouble getting a hold of the DME providers. And that's really a systems level issue, but actually fixing that systems level issue improves CPAP compliance. But just telling people to use their CPAP or educating them about sleep apnea did not help. So just a little bit of information about what might help your patients wear their CPAP more. Okay, what about if nobody in this group chose gabapentin, but it is a high-risk medication. And so what's the data behind this? So this is gabapentinoid. So this includes gabapentin as well as pregabalin or Lyrica and cognitive risk. So again, kind of looked at the data here. So in a retrospective matched cohort studies of older adults using gabapentin, they had an increased risk of cognitive decline and functional decline that was dose dependent. So higher doses is higher risk. And they also had increased risk of hospitalization for altered mental status. And again, greatest risk at greater than 600 milligrams a day. And remember, our guy was on 600 milligrams twice a day. And then similarly, an increased risk of delirium postoperatively, especially if they had renal disease, which makes a lot of sense because we know these meds are renally cleared. And then this data here that I have the picture for was a placebo-controlled, randomized controlled trial of pregabalin, a small n, but was powered. Pregabalin and it reduced cognitive performance and increased cognitive complaints in healthy older adult volunteers. So those people without any kind of cognitive impairment. And then so what you see here is pregabalin in green, you see the placebo in gray, and then lower is worse here. So these people had worse, cognitive performance in all of these different tests that are green and starred. And then here they also reported worse confusion and worse neurotoxicity symptoms. And again, these were healthy people. So I've been thinking a lot about these medications and cognitive risk in my patients as well.
Dr. Jennings, you have a question.
Okay, great.
Okay, so there are several medical issues to address and check in this patient consistent with the choices. But to address his primary concern, some type of screening for cognition and mood would not be inappropriate as a first step. OSA is part of the diagnostic evaluation. This question is coming from Dr. Monica Parker.
She is correct. So this case was in part designed for me to allow me to kind of talk through some of these different risk factors and what you might think about in primary care. But I agree that doing a MOCA or another validated cognitive screener to further assess the patient's complaint would be completely reasonable. I'm actually not going to talk about that because I think we all agree that that is part of kind of what we would do in care. The one caveat I would say is that sometimes when we do these screeners, when people have untreated risk factors, I try to go back and redo the screener because sometimes they will then perform better. Once you've treated their sleep apnea, you've got them off high risk medications and things like that, they may actually perform better because they have less direct impact on their CNS from treating those things. And so that would be the only thing I would add, is just to consider going back and re-looking at it, as someone may actually perform better once you've addressed those risk factors.
Wonderful, thank you. If there are other questions, please use the Q&A or raise your virtual hand, and we'll pass those questions on to Dr. Jennings. Please continue, thank you.
No problem. So one of the things that's hardest about trying to reduce high-risk medications in patients is getting them on board with the taper plan. And then one of the other things that I want to point out is that we often, as clinicians, taper too fast. So people have more withdrawal symptoms, and then they give up, or they increase their dose back, and then it becomes actually harder to try to taper again. And so this is a website from the Canadian Deprescribing Network that I found very useful in my own practice. And this is the risk tool that they use for gabapentinoids, but they similarly have some for benzos, they have them for opiates. And what they go through is they really do kind of this informational and then motivational interviewing kind of component that it's all patient facing. So all the materials are patient facing. So they go through a true false quiz with information. They go through a side effects questionnaire. So sort of to have the individual reflect on how the drug might be impacting them personally. And then they go through other ways to manage the symptoms for which they're taking the medication, recognizing that they may need to do other interventions to replace whatever potential benefit they were getting from the pain medication. What I often find is that people's benefit has stagnated, right, or declined over time. And so sometimes they actually will get more benefit from doing these other interventions as we're coming off the medication. And then I think the most useful piece is the last page of the patient tool that has a tapering schedule. And it's nice because it'll go through a full dose, 3/4 of a dose, half a dose, a quarter dose, so people can actually split their pills. Now, sometimes the pills are small, or if they're a capsule, you may not be able to do this. You may actually need to order the lower dose. But I've had people be fairly successful with taking this home and beginning a self-taper. And I think I'm pointing out that you're really just going to decrease it by 1/4 of the dose in the first week, and then for BID dosing, and then that it's really slow, so that you're taking it over 6 weeks, not just 2 weeks or so to get off to decrease the dose. And I also tell people, like, look, even if we don't get all the way down to off of the medication, if you get a lower dose, if you can tolerate half the dose, that's a win, that's a benefit. We've reduced harm potential harm for you. So anyway, I encourage you to take a look at this website here. I found it to be pretty helpful, and all of these tools are freely available. Okay, what about GLP-1, so meds? So these are hot right now, right? Lots of people coming in and asking about these medications, actually kind of hard to get covered for patients who don't have diabetes. But what's the data for diabetes, drugs, and dementia? And so there's been some recent studies actually, and JAMA Neurology just came out this year. This was looking at 23 different randomized control trials of over 160,000 patients. Most had type 2 diabetes and the mean age of 64. And they looked at, and they had 12 randomized control trials of SGLT2 inhibitors and 10 randomized control trials of GLP-1 receptor and agonist, drugs. They were followed for almost 3 years, on average, 31 months. And they looked at incident dementia or cognitive impairment. So these people did not have cognitive impairment at baseline. We don't really know if you already have cognitive impairment, whether these drugs are helpful. So these are before people have incident disease that's clinically detectable. And what they found was that the GLP-1 receptor agonist medications were associated with a decreased odds of dementia with an odds ratio of 0.5. And so this is the forest plot here. So these are the SGLT2 up top, and this is the GLP-1 receptor agonist on bottom. And so lower odds ratio is decreased risk. So you can see kind of mixed results here, and then our diamond is fully on the other side for the combined outcome over here. And then another study, this was a target trial emulation study. So that's a design observational study where they try to mimic randomization to intervention or control. And what they did here is they looked at both GLP-1 and SGLT2, and they found, and this is the GLP-1 versus other glucose lowering drugs. This is SGLT2 versus other glucose lowering drugs. And then these are the two drugs versus each other. And what they found was that they had a decreased risk in the GLP-1 and the SGLT2 meds, but there was really no difference with either, comparing the two drugs to each other. And what they also found was that if you had cardiovascular disease, that the impact was greater. So they had a 4.8 and 4.6 absolute risk reduction for people who had prior cardiovascular disease. So I think still more work to be done, but again, sort of supporting that hypothesis that improved control of diabetes improves vascular health, which then decreases potential cognitive risk for people going forward in time. And so this is kind of the highlights of what we covered today. So I think there's pretty good data that we can at least delay the onset of cognitive symptoms through lifestyle and public health changes. I hope I've made the argument today that brain health is a really important part of preventative care, even for people in middle age, especially for people in middle age, and that we have the ability to address some of these risk factors. And here's what we covered. We covered specifically sleep apnea, we covered tapering high-risk meds, and we covered a little bit about diabetes and dementia risk. And so with that, I'm happy to take more questions.
Thank you so much, Dr. Jennings. Yes, if you have questions, feel free to raise your virtual hand or enter your question in the Q&A.
And should I go ahead and stop sharing? Will I be able to see?
Questions you should be able to. Would you mind going to the next slide? We'll just mention
Oh,
the
right. So sorry, I forgot my acknowledgement. So this is
No
our team
problem.
at Oklahoma. We have a geriatric workforce enhancement program that supports a lot of our work in Oklahoma, and our fantastic partners, Oklahoma Foundation for Medical Quality, Alzheimer's Association, and our other colleges on our health professions campus. And then we also have the OU Health Memory Care Clinic, where we see a lot of people with these risk factors and cognitive complaints. And so that is actually, I think, my last slide, correct? And then here we are.
Right, and wonderful. Thank you so much. And this is a CME activity. This is the information to actually claim credit and also complete an evaluation. And Kim will follow up with an email with these details as well. So please feel free. There is a question in the Q&A. If you can see it, let me know. Otherwise, I'll be
now. Do you suggest screenings for plaque buildup, for example, lifeline screens? I have not seen data to support that. I think that the data that I showed today, at least how it's impacted my own practice, has made me really think that if I'm seeing a patient with cognitive impairment, it's very likely, based on that first neuropathology slide I showed, that they've got some vascular risk. And so then it's a matter of weighing benefit versus potential side effects and treatment burden with that individual. So if someone has a long life expectancy and has, time to benefit from the cholesterol medication and is interested in taking medications, and especially if they have other risk factors that maybe make that more likely, then I would, be thinking about that. I think the data for primary prevention for statin, I think over 75 for cardiovascular risk outcomes, is mixed, right? It's sort of a shared decision making. It's pretty clear that if you've had a cardiovascular risk outcome, we should continue that for secondary prevention. But for primary prevention, I think it's still it's very much shared decision making. And I do think as people develop disability, right, when I'm thinking about my geriatric patients, that burden versus benefit, I think, becomes, narrower. But when I've got a younger person, maybe someone in their 60s who's seeing me for primary care, I really am thinking about being more aggressive if brain health is one of the things we're, trying to prevent for them going forward. But I don't have any data. I have not seen data on screening. In fact, my understanding is that screening for things like screening without symptoms, so no BRUI, no other reason, that screening for like carotid artery disease is not recommended. So it's sort of one of those like choosing wisely things to recommend against. Okay, so then the next one is, am I familiar with group intervention at a primary level care, like education groups done in primary care to help more individuals? I did not look into that specifically for this presentation. The data that I presented around around therapy would really be cognitive behavioral therapy for insomnia and for adherence to CPAP for OSA. That did show improvement in adherence and use CPAP. But as far as, and I know that there are data in the diabetes literature around group interventions for primary prevention and prediabetes, and as well as adherence and use of insulin and things like that for diabetic patients. But I don't know of any data specifically related to brain health for that. Okay, and then ordering a brain MRI with significant risk factors, if those with type 2 diabetes, hypertension, strokes, arrhythmia, when to refer to a neurological service? This is a good question. So, in a person who does not have cognitive complaints, and no signs or symptoms of a stroke or other reason, I don't know that I would order a brain MRI. Brain MRI is actually also not very sensitive. It may show kind of nonspecific white matter changes consistent with vascular disease or generalized atrophy appropriate for age. And we don't really know what to do with those data necessarily. Like that's not gonna, it often doesn't impact your practice. Now, if I've got somebody like this coming in with cognitive complaints, I've done a MOCA, it's abnormal, you know, a brain MRI or at least a CT, MRI is preferred, would be part of that workup. So I think in this case, I would think about a brain MRI. And then referring to neurology, we are often referring when people have abnormal screening tests, they have they have concerns and they have an abnormal MOCA or screening test, then we're often referring for MRI, and then we're referring for neuropsychiatric testing. So we have the ability to do that. And then based on those test results, if people would like to see a neurologist or have an atypical case or atypical features, or they are interested in potentially in some of the new monoclonal antibodies for Alzheimer's disease and further testing because they would be a candidate for those medications, then we are referring those patients to neurology. So I hope that helps.
Thank you so much. Those are all the questions that were in the Q&A box. We appreciate your time and the information you shared with the group. And thanks, everyone. And we'll see you next month on August 20th, where Dr. David Loring will present on high cognitive reserve. Thank you so much, Dr. Jennings. Have a great week, everyone.